I want to welcome everybody to our September speaker series for the Concussion Resource Center. It's our first virtual one, so it's a little bit of a new thing for all of us. When COVID happened, we just kind of put the speaker series on hold. And usually we do it more September through, September, October, and then we do January, February, March, April, May. And we will talk at the end about our next presentation that we have planned for October. But today we have two of our board members speaking. I'm going to tell you a little bit about each one of them. Nancy Astrup, both are physical therapists. Nancy graduated from Northwestern University Medical School in 1984 with a bachelor's degree in physical therapy. Her initial physical therapy experience was in acute neurological rehabilitation at New Hope in Billings, and then an outpatient orthopedic setting at St. Vincent's Hospital in Billings. So she specialized in vestibular therapy since 1998 and completed her certificate of vestibular competency at the University of Miami in 2000 and advanced vestibular competency at Johns Hopkins in 2003. So since that time, her interest and focus has been working with patients who suffer from a variety of issues involving dizziness, post-concussion, balance disorders, and vertigo. She's been working to educate the medical community and the general public as to the importance of vestibular assessments and effectiveness of vestibular rehabilitation in managing patients who suffer from these disorders. So Nancy lives in Montana, has been living here since 1984, and has been with APRS for the last 33 years. And she joined the Concussion Resource Center board in 2019. And as far as Brittany is also a physical therapist at APRS in Bozeman. She graduated with her doctorate of physical therapy from the University of North Dakota in 2011. Brittany began her career in Phoenix, in which she advanced her skills and knowledge in vestibular and orthopedic therapy before returning to Montana and joining the APRS team in 2018. She continues to see and advance her skills in treating orthopedic and vestibular patients, and she's been treating people with concussions since 2013. She joined the Concussion Resource Center also in 2019. So with that, I'm going to have Turi, who's more of our technical person and one of our board members, explain a little bit more about how we'll manage the Zoom aspect of it or the virtual aspect of it. Take it away, Turi.
Sorry, I had muted myself.
That's part of what you're going to tell us about.
I have a puppy in the room with me, so I will stay on mute through most of it. Thank you for that introduction, and to Nancy and Brittany for being here. For anybody that's new to Zoom, just a quick overview. I know most people have used it, but just for anybody that hasn't, there's a couple different ways you can view the presentation. Nancy and Brittany will be sharing their screen for the visual presentation. If you want to see pictures of participants or a speaker, if you go up to the box where you see people's faces, you can see your options there of a speaker video view or a thumbnail view or a grid view. And if you click on the different ones, you'll see how they display differently. So it's chosen by you on your end, how you want to view that. Through the presentation, we'll have everyone on mute just to minimize background noise. And then in the end for the Q&A is when you can come off mute and ask your questions. You can also type up your questions in the chat box. So in the bottom navigation bar, there's a chat icon. So if you click on the chat icon, you can write your questions in there, and Brittany and Nancy will take a look at those at the end for the Q&A.
Okay.
And as far as the video goes, we are not capturing anybody's faces in the video. So just to let you know that, not to worry about that, I'm only capturing the screen presentation. Thanks.
So take it away.
Okay. Well, Brittany and I are happy to be sharing information on concussions, and we're looking at how physical therapy plays a role in the treatment of concussions and management. Some people are aware of it and some people are not. So we're happy to be sharing this information. Some objectives that we want to, or points we want to cover. One primary one is that concussions are treatable. So some people think they are not, but they definitely are. We'll discuss how the research over the years has changed how we treat concussions. And we'll be looking at the risk factors of concussions. A primary thing we'll look at is the clinical profiles or classifications that as physical therapists we look at relative to concussions. And those classifications directly lead to how we treat concussions. And we'll be talking about that. What we do in PT for concussions, what our goals are in physical therapy, and then at the end we'll have information for resources for people just on concussions and management of those. Just briefly, a few statistics about concussions: 1.8 to 3.6 million concussions per year. That's for athletes and recreational athletes. That doesn't include motor vehicle accidents. The two primary symptoms post-concussion are headache and dizziness. And 50% of parents don't think that there's a cure or a treatment for concussions. So as we talk about vestibular rehab, what is vestibular rehab therapy? As physical therapists, this is what we call the therapy when we treat people with symptoms of dizziness or imbalance or post-concussion symptoms. So vestibular therapy, vestibular rehab is a specialized form of physical therapy that's used to reduce dizziness and balance disorders or any other disorder that affects the vestibular system. And following a concussion, any one of these systems can be affected and cause some issues with dizziness and balance disorders. So the three sensory inputs that the brain utilizes for balance is our vision, the eyes, somatosensory, which is another word for having sensation in the body or touch, and knowing joint position. We know where our limbs are in space because of this system, the somatosensory system. And then the vestibular system and the inner ear system. And as I said, any damage to any one of these systems can result in symptoms. So a vestibular physical therapist is someone who provides vestibular therapy and has specialized training in dealing with these issues. So just a brief overview of what is the vestibular system. That word many people are unfamiliar with. In the clinic, we often get asked, what's the vestibular system, or what's a vestibular therapist? And the vestibular system, as we look at it, is the inner ear. And in the photo, the inner ear is the purple structure on the inside. So you have the external canal, the eardrum, and then deeper in the head is that labyrinth, or that inner ear. And the picture on the right, you can see the little snail-looking part is the cochlea, and that provides the hearing. And the other half of that structure is the labyrinth, which consists of the semicircular canals and other structures in there. That structure is made of bone, and it's embedded in the skull. And the size of that structure on the right would fit on a dime. A dime. It's very small. So that's the vestibular system.
All right, so now we're going to talk about what is a concussion. In the most basic terms, a concussion is a brain injury. If we take a look a little further, the medical definition is a complex process affecting the brain that can be caused by a direct blow to the head, face, neck, or elsewhere on the body that is transmitted to the head and results in impaired neurological function. Taking a look at that, the sudden movement can also cause the brain to bounce around or twist in the skull, which can create chemical changes in the brain. So with all that being said, a concussion can happen from a blow to the head, but you don't actually have to hit your head to have a concussion. It's the movement of the brain inside of the head. So a lot of times we hear people like, no, I didn't have a concussion. I didn't hit my head. Well, you don't have to hit your head to have a concussion. It's how the brain moves inside that head with a velocity being placed on you. Some risk factors for concussion: being a female makes you a higher risk, a history of a previous head injury, different mood disorders, some different learning disorders like ADHD, OCD, dyslexia can make it a little bit more difficult for recovery or can cause symptoms to last a little bit longer. Same thing with migraines. If you have a predisposed history of migraines, that migraine could come with the concussion and be a little bit more difficult to treat. And sleep disorders. The brain really heals when you get good sleep at night. So if you have a sleep disorder and your brain isn't able to go through that healing process or go through that recovery process during sleep, it can make things difficult and increase risk factors to having a concussion. So right here, the pretty colorful picture on the right, which looks like this, we gave to you in your, I think Kathy sent it it's included in one of those handouts, but what this is showing is kind of what Nancy talked about in the beginning as the different trajectories or the different parts that we're looking for as physical therapists. So one concussion is one concussion. We hear at courses and stuff, it's like a snowflake, everyone's different. Or if you've seen one concussion, you have seen one concussion. Because all concussions can take on a different role and all concussions are very individualized. Even if it's the same person who's had a second concussion, they can have different symptoms. So if you take a look at the diagram there that has all the circles, we have the concussion in the middle. And then there's been a lot of research breaking it down into different trajectories or different parts of that concussion. So the vestibular part on top, that's where Nancy and I special in, and we kind of showed you the picture of the vestibular system. So that the vestibular, we're looking at balance, we're looking at different dizziness, those kind of things. The ocular motor, we're looking at how your vision plays with different things, reading, busy environments, sensitivities to different lights, just how your eyes work in your surroundings. Cognition, post-traumatic migraine, cervical. So again, if you have a whiplash injury with that concussion, it can cause different neck problems, and then anxiety and mood changes. So through our evaluation, we take a look and we break people down into what they're having trouble with. So I often tell my patients, your concussion is kind of like, it's like a pie. And you might have your vestibular piece might be 50% of the pie, and then you might have, 30% of ocular motor and 20% of cervical. So it really takes a multi group effort to treat concussions. I mean, as physical therapists, we don't see people for anxiety, mood, or cognitive issues. So it really takes a multidisciplinary approach with different disciplines like speech therapy, your doctors, psychology, eye doctor. I mean, there's a big group of people depending on what each patient falls into.
So what can you expect, or what is done when the therapists do an evaluation after an injury? As Brittany said, as we go through the exam, we're trying to look at those classifications or those trajectories, and through our testing, we determine which is the primary, which is the secondary. We kind of put them in order, and that is how we progress through our treatment. So one of the main components of our evaluation is an ocular assessment, and that's looking how are the eyes moving, how are they coordinating when the head moves and when the body moves. There's a test called the VOMS, which is the Vestibular Ocular Motor Screen, and that was developed at the University of Pittsburgh, and who are very active in concussion treatment, and we've been using that for years. It's a brief 5 to 7 minute test that looks at various eye movements, and we score how symptomatic those eye movements are for the individual. And that has been shown to be 90% accurate and concluding that a concussion has occurred. So that's an important part. Of course, balance testing, we do a variety of balance screens. We do Romberg testing, standing in different positions, standing on different surfaces. We do functional testing, so a dynamic gait assessment is done. So that would involve a series of tests, walking with turning the head, doing different motions of the head, different speeds that are walked, and we score this out so we have very objective tests with functional testing. Near point convergence is looking at how the eyes track. If you hold your finger out and bring it in close to you, your eyes will converge in, and we take certain measurements of near point convergence. That's actually part of the VOMS test that's included that I mentioned above. And a post-concussive scale, that is a questionnaire of 22 questions that we have patients complete. They complete that on how symptomatic they are. Before we do a baseline test of that, so someone will fill that out, answering questions of how they were, if they have any of these symptoms prior to the injury, and then what their symptoms are since they've had a concussion. Some questions include headache, sleep, fatigue, and just more detailed questions about that. But we want to know if someone had difficulty sleeping and they had headaches prior to their concussion. We need to know that, and that's helpful when they complete the concussive post-concussion symptom scale of doing a baseline and then a post-injury. Now, based on that, the results of our testing will put patients into, as Brittany was talking about, the pie. So someone may come in and their only symptom is headaches. They have no other symptoms but that. So our treatment will address the post-traumatic migraines. If someone comes in and they have all 6 of those subsets, then we have to prioritize which is the most disabling to that patient. We essentially work with all of them, but we do prioritize those so we can get people back to work and get them functioning again. So based on how they test and based on their complaints and their functional limitations, we'll determine where we progress our therapy. So I'd say many people do have have balance issues. So therapy will include various balance training. We do it in lots of different ways. We try to make it as dynamic as possible because people need to move and function. So it might be on a firm surface, a hard surface, they may be doing where they're rapidly moving. We try to replicate things that would be consistent with the job that they're going back to or what they have to do at home. Gaze stability would include how the eyes work, how the eyes track. Can the eyes stay focused on a target when the head and body is moving? Which gaze stability is a very common problem that we see after concussion, and we do work heavily on that. So we can combine gaze stability exercises while they're doing balance work. Try to multitask, and then that brings in the cognitive part. So it's not just one exercise at a time, but it can be a multitude of things that we work on. Activity and behavior modification. Behavior modification was listed in the handout as well. We want to address sleep. We want to address hydration, diet, not napping during the day. How do you know how far or how active to be, and when do you know when to stop? And those are all things that we use as guides and instruct patients on, so that when they go back to their activity, they know they have guidelines and very, very specific things that they know how to stop and recover before they resume that activity, so the symptoms do not escalate. We do know if people push past a point, for example, dizziness. Let's say a starting dizzy level, if we're using a 0 to 10 scale, is there, someone always has a low level of dizziness that's a 2. As we progress through various activities, we don't want them going higher than a 4. If someone pushes and pushes and pushes and their dizziness gets so bad that they're an 8, oh, that's tough. It's hard to recover from. It can take hours and days to recover, and it just can set people back. So we help to instruct people of how to know, how to gauge their activity, when to back off, when to push. We do job returning to activity training. So we want to know what people do for a living. What do you need to get back to? Do you want to go hiking? Are you a runner? Are you a swimmer? We try to get people doing activities so that they can return to those activities of recreation as well as work. And then graded exertion programs. It's been shown that we need to get heart rates elevated. We need to get blood flow through the brain, and we need to push people a little bit. And this also gives us an idea of how far to push and helps us to instruct a patient how far they can push, and again, when they need to back off. So those are all part of the rehabilitation that we do post-concussion. See if I did not include also cervical spine, as Brittany mentioned. So when there's been an injury, we also assess cervical spine, and that's treated as well. I think that's it for that one.
All right, so the goal of concussion rehabilitation. So kind of going back to when we first started and look at all those trajectories. So first, we're gonna put people with their specific symptoms into what's primary, what's secondary, and figure out a treatment plan on what's the best approach to get them to feel better, right? And then going through some of those special tests that Nancy talked about to see what level are they at now, able to probably provoke symptoms, but able to recover quickly, able to recover in less than 5 minutes after provoking. That's how the brain's gonna learn. If we provoke a little bit, that's the brain's way of telling you that you're confused. It doesn't know what's going on. It's getting a little bit overwhelmed. So how Nancy was saying, we don't wanna get you up to an 8. If the symptoms start real low and they're getting up to an 8, your brain's getting overwhelmed. And if it gets to too high of levels, it's not able to recover. And that's where the setbacks happen. And that's where it takes hours to days to recover. So we really want to, with this type of therapy, you are going to get provoked a bit. We want to provoke it a little bit so your brain realizes, hey, it's okay. I'm not getting overwhelmed. And that's why we make sure that you rest as soon as you get up to above 2 of what you started from. So then those symptoms can calm back down. And we keep pushing it at these little increments. Now it's starting to understand that, and you're able to go for a longer duration before you get up to +2 of symptoms, or before you don't need to take any breaks. So that's kind of when we're kind of throwing all those things together. We're taking a look at what's primary, what's secondary, what's tertiary, and then we're running through those objective tests to kind of help us figure out what level can we push people to without overwhelming symptoms, but to where they can also be successful and see those changes coming every day. So when we take a look at the goals, our ultimate goal is to get people to pre-injury activity safely and minimal risk of re-injury. So if your balance wasn't that great before and that perhaps maybe caused a fall, we want to make sure that we really focus and get that balance up to where you now have a low risk of fall and different things like that. We like to get people to asymptomatic at rest and with full activity. Sometimes it's when it's activity, as we get going, the activity becomes more challenging because you're able to tolerate more. So we're going to try to get you back to being able to run what you were able to do and things like that. But once we introduce new activity, with that being said, sometimes then you start to feel symptoms a little bit. It's not because you're staying at the same place, it's because your brain's being challenged at different levels. So our goal is really to get people back to the activity of what they were previously, if we can. We do reassessments with those tests about every, depending on the person, but like 4 visits to a month. It depends on, it's all individualized, but we'll retest you on the test that we did previously, and then we compare where you were then to now and just kind of see where things are going and adjust and modify our treatment plans based off of that. We want to get people off the medications that they might have had to be on when the concussion happened. Sometimes people have to get something to help with sleep or pain or different things to help them get a jump start to feeling better. And then all those tests, that VOMS, especially we want to try to get that ocular testing to be normal, to where you're not having an increase in symptoms, but also to where your eyes are moving the way they should. And with that comes a normal balance as well. So in summary, management of concussions is best with a multidisciplinary approach. So like I said, I mean, you have to have a good team working together. As physical therapists, we're able to address a portion of a concussion. So we have to work with a team of people depending on the concussion and depending on what categories that person fits into. So back in the dark ages, they used to say, go into a dark room and just no stimulus at all. We've found research and over, especially recent research in the past years, saying that that's not the case. You really want to start moving and being active, but with those guidelines in place, because if you're too active, you're going to overwhelm. But if you're in a dark room, your brain's not getting any stimulus as well. So one of those things are, I don't even know what to say, but what that says is I'm trying to think of the word that, cinnamon? No. A dark room is an oven that cooks up all sorts of problems. So yeah, when it comes to a dark room, we want to not stay in there until your symptoms go away. And then if we look down below, so the Concussion Resource Center is putting this on. They have a great tools and information and education, as well as some different yoga series and meditation series. So that website right there has a lot of information. Vestibular.org has a lot of information on concussions and also other vestibular conditions. And then the one below that, that's where those trajectories and some of those things came from guys that rethink concussions. So they've done a lot of research, and they're continuing to do research on concussions and management. So they're a source that we look to often for what's up and new and coming. And so we wanted to give that to you as well. And then just to kind of recap, as far as handouts go, we have this handout that should be included about some of those behavior modifications, the trajectory one that I had mentioned before, and then also this little fun little handout about different myths and facts with concussion. So that should be on a link that you had emailed to you. So, any questions?
I have a whole bunch, but I'm just very naive to concussions. I got concussions numerous when I was in my teenage years and in my 20s. Now I'm in my 50s, and it's almost more of a curiosity about how that's affecting my behavior today. I know I used to have excellent memory, and I don't anymore. And that's not something that's just come on in my 50s. So I guess the one thing that was surprising is a female's brain different than a male's brain? Why are women more susceptible to concussions?
Some of it has to do with neck strength. You know, just to get that momentum force for that brain to shear and move around. Women in general have a lot have necks that are not as strong as male. So their neck can go through more of one of those whiplash episodes.
There's also some thought that women report them more. When they're symptomatic, women are more likely to bring it up.
Right.
And men are less likely to do that. And then the neck strength has been fairly well studied. Yeah.
I'm sure there's studies that I could find. I'm just wondering, you know, having my first concussion when I was 14, that's a pretty vulnerable place in your brain development, I would imagine. So I would imagine your age has something to do also with the implications of concussions, their severity, and maybe how the lasting effect of them. Like if I got one in my 40s versus when I was 14, I would imagine that it might be different. But then again, you said every concussion's different, but it just seems to me the teenage brain is more vulnerable.
Yeah, I feel like there's not a lot of research as far as studying someone when they're 14 that had a concussion and then re-looking and examining that person at 50 to 60. There hasn't been that much research in that, I would say, yet. I would say that would be coming, but as far as recognizing and treating concussions, it's been fairly new compared to if you look at that 40-year, time span.
So you could be tested now. We may not know what effects you had at 14, but we know what the norms are for someone your age. Mm-hmm. So you could have testing and know that you're within the normal range, or maybe there's an impairment with this or that. And that we have pretty good information on. And
so then there's still a chance to move me in a positive direction if I were not in the normal range, like that this doesn't have a time limit on it?
No, because once it's determined where perhaps the restriction is or the difficulty maybe that your brain is processing or something, with that information, then we're able to give you hopefully give you tools or take you through some things that are going to push that system, and then you're going to see improvement. Now, how fast you see improvement can be variable, but typically you'll see improvement. It can be quick or it can be over weeks, but very much able to improve. Like if it's balance, that can be improved. If it's cognitive, and I would turn the cognitive stuff to Kathy. As far as processing, maybe there's a processing problem, but with testing, you can kind of see where is the glitch, where is there maybe something that's held back a little bit, and then that would then determine what would be maybe helpful and beneficial.
Well, that's very positive. I thought that it was a foregone conclusion at this point, so that's positive news. Thank you.
Yeah, you're welcome.
So I was going to chime in just a little bit. As far as the younger age, sometimes it is better because your brain is more neuroplastic and it will adapt faster. Some things haven't been totally developed at age 14. So as far as your executive functioning skills, so you may not even know if those have been affected, but
they never develop.
But so sometimes, the younger isn't necessarily that it's worse and it, went on prolonged. It might've had a faster recovery at that point in time. And then I was going to chime in about the executive as far as memory and that type of stuff too. There's things that can be done and at least find a baseline of where you are. And then in therapy, it's actually kind of mirrors some of what they do as far as PT does, as far as we want to assess it. We want to be able to then come up with some strategies to help you, and then actual exercises that could to benefit you and improve those skills.
It's good news. I just thought it was a foregone. I actually never associated the fact that my memory is not great with concussions. It happened so long ago that it's not on my radar. And maybe it's not just that, but my sister actually pointed out, she said, you used to have the most phenomenal memory. Did you smoke too much dope in college? And I'm like, I think so. I don't think that's the problem. I mean, she just noticed it. I was like, I think it almost takes someone external to you to maybe pick up on things that become normative to you. So, but I probably had 5 or 6 serious concussions. So it's not just like I'm talking about one.
Yeah, that's a
It
lot.
scares me a little bit. You start watching those shows like on, you know, concussions and what that means long-term and your long-term brain health. And yeah, that's Susanna's like, I think you should probably participate in this webinar. And I'm like, okay, yes, I could be an Alzheimer's candidate and I hope I'm not. So.
Yeah.
Well, good question.
That's actually a good lead into our next presentation
I'm sorry,
in October.
I went on and on.
No, that was great. Great questions. No one's chatted.
So I have 2 questions for you. One is, you had said no napping. I've had 2 concussions in the last 6 months, and incurring a phenomenon where when my brain is worn out, I kind of cut out no matter what I'm doing. So I was playing with the children the other day, and then next thing I know, I was asleep for a few hours. And then 2 nights ago, same kind of thing where it just cuts out. I find if I do take the naps when I'm experiencing high symptoms, it allows me not to have the unexpected times. And in both cases that happened recently, they couldn't wake me. So I just was out and done. So what is the theory behind the no napping?
Well, and maybe I said that incorrectly as far as no napping. I'd say brief napping. So we would discourage a 2 to 3 hour nap during the day, especially if you're not having normal sleep at night. So ideally you want to get as close back to your normal sleep pattern. So going to bed at the same time as you did before and waking up at the same time you did before. It may be a little bit longer. And cat naps during the day can be somewhat helpful. It's been shown more like a 10-minute, 20-minute nap as opposed to a 3-4 hour nap. So the napping can be helpful. And I guess my question would be if you're sleeping your normal napping at night, as opposed to, if people sleep a lot during the day, then it disrupts their sleep at night. And then that gets to be a problem.
In general, I've been sleeping more than I ever have. Usually I don't go to bed until after midnight and get up very early again because of everything I'm doing. But now I'm in excess of sleep and the nap's not disrupting anything. The other thing I was wondering, when you talk about exercise, does general exercise and blood flow, that's something to be encouraged?
Yes. Especially early and later in a concussion, especially early, we know that the cerebral blood flow is important in the brain getting nutrition. So it may be in early stages, it may be a very slow walk for 5 minutes. But getting some type of movement is greatly encouraged. At the same time, you need to watch the symptoms. So if you're having a bad migraine and you go for a walk and that migraine escalates, then that may not be the activity that you want to do at that time. So it would need to be a specific type of activity that doesn't at the same time elevate symptoms. So it would depend on, walking is one of the best things that people get started with fairly early.
Or like a stationary bike or something like that if walking is too much. Yeah, it depends on the person and what their brain's able to tolerate to push, but not overwhelm.
Yeah.
Well, the walking has been very helpful. The music, so it reduces the sensory overload. But I have a stationary bike. I have not returned to it yet, but that has been my intent.
Yeah, and that can be good because there's not a whole lot of head movement. You could not a lot of visual stimuli, so you could do that in a dark room if you needed, or with less light. I don't want to say dark room, but that's a nice way to maybe start getting the heart rate elevated a little bit.
The goal is for the person to be able to get about 20 minutes of some type of exercise that they're not pushing into those overwhelming levels, but to be able to maintain, to get that heart rate going.
No, hiking's not a problem, but you're right with the head motion. My 3-year-old wanted me to dance the other day, and I had too quick, and it realized that I'm not going to be doing that again anytime soon.
Yeah.
So I mean, one way that you could start to do after you're able to walk for longer periods of time, you could start walking and then just kind of slowly just kind of looking side to side to start to incorporate some of that head motion. And if you're walking with someone, walking and talking and kind of turning and looking at them, those are just some little ways that you can progress if right now you feel like you're just you can't really move that head much without getting overwhelmed. As that gets better, you start to incorporate some of that into a degree.
Thank you.
Mm-hmm.
I have a question. Can you hear me?
Yeah. Mm-hmm. Oh, now we can't.
Hear me? Okay, thank you. Now can you?
Yep. Nope. Yep.
Wait a minute.
No.
No. One more. You had it on. You had the microphone on. We saw
okay,
it. There you go.
Okay, sorry about that. Luddite here. I had a concussion 30 years ago, and then one again 8 months ago, and this time ended up with post-concussion syndrome, where symptoms just lingered and lingered and lingered for months. Is there a correlation at all between previous concussions and post-concussion syndrome? Is that more common in women? And I mean, what can you tell me very briefly about, post-concussion syndrome and the lingering effects? Is there?
Shall we? Okay. It is known, as Brittany had mentioned, some pre-existing, if you've had a prior concussion, you have a projected recovery, a longer recovery if you have another one.
Okay.
And that's been fairly well supported in the research. But we would treat them the same. So if you were assessed, we'd need to see what part, where are you struggling? And the treatment would continue based on your symptoms. But things like a prior concussion, a prior history of motion sensitivity, cognitive issues like ADHD or a learning disorder, we do know that those people take a little longer to recover.
Okay.
We just took a class. We're in the process of taking a concussion summit class this week. And one of the big things that they're stressing and that's coming out is they're trying to get away from using post-concussion syndrome, because technically, I mean, it's all these symptoms that define what you have from your concussion, but that syndrome word is just, it's for people, it's like, oh, I have this syndrome, and really. And so, so it's been very interesting that they're trying to kind of rephrase with using those trajectories. So you can be a little bit more specific because, like what does that mean? And so that was kind of pretty eye-opening for us because we use that terminology all the time and in our documents and things like that. But to be more specific with using some of those different trajectories are what is your concussion like? What are you having problems with? So I just found that interesting. So I wanted to share with you.
Okay.
And we do know that sooner the better. Getting in and getting tested, you're gonna recover better than if you wait.
Okay, interesting. Thank you.
And I think also the point that Brittany made, and probably Nancy said it too, but one concussion is one concussion. So it's, you know, it could be very different from the concussion you had when you were younger. It doesn't necessarily mean because of age or because it was cumulative. Just each concussion can be very different in that recovery as well.
Yeah.
Any other questions? All right, make sure there's nothing in the chat. Oh. All right.
So
I want
did
to
you
thank you for all the
mention-
questions. I was just going to say it's great discussion. I think it was helpful for everybody probably to hear those questions. So thank you for sharing. Nancy, do you want to tell us about our next series or next
Yes,
speaker?
so next month, October 15th, I believe a Thursday, we're going to have Susanna Freeman, who is an acupuncturist at in Bozeman, and she will be talking about acupuncture and how that can be beneficial for someone who has had a concussion, how she treats that, and she'll also be addressing a little bit of nutrition issues relative to the acupuncture realm in that field. I think it may be like Chinese herbs and things like that, but what she uses when she is treating someone with post-concussion symptoms. And that'll be at the same time, I believe, at 5:30 on October 15th. So.
Just a little plug for the Concussion Resource Center. If you are interested in learning more about what's going on, if you can go to our website and join our mailing list, then you will get our monthly newsletter that will tell you what events are going on, what the speaker series will be, etc. We try not to bombard you with emails, but at least you get that once a month. And then, as Nancy said, there's lots of resources, and Brittany, there's lots of resources on that website as well.
Well,
So if there's nothing more, I want to thank everybody for attending. This is great.
Yeah, thank you.
Thank you.
And we did record it, so we're planning on posting it. You can either contact me again through the email address that you did for the Concussion Resource Center at gmail.com, or look on the website, and we should be having a link at some point in time for that. Okay.
And if there's any questions that come up later, people can call the office and leave a voicemail for Brittany or myself. And if there's something you thought, oh gosh, I forgot to ask, we can respond that way as well.
Yep. Or shoot us an email too. Our email's on the site as well.
Thank you, ladies. It was very interesting.
Yeah.
Yes, so much.
You bet.
Thanks, everybody.
Thank
Thank
you.
you.